Hello friends, today we'll be discussing about femoral hernia. So before starting, I would like to thank Chandana Shri Ma'am for sharing the wonderful notes with us. These are very helpful for revision. The link for the notes is given in the description below. You can download it from there. And so without further delay, let's get started. So first of all, we will see the anatomy of the femoral canal. So femoral canal is the tunnel in the anteromedial aspect of upper thigh, and it starts from the femoral ring, which is there in the upper aspect of thigh near the inguinal ligament. And as we can see in the diagram, that it starts from the femoral ring, and this femoral ring is formed by the fascia transversalis and inguinal ligament, iliopubic tract anteriorly, and the Cooper's or pectineal ligament posteriorly, lacunar ligament medially, and septum in the laterally. Lateral to the septum is the femoral vein, and even more laterally is the femoral artery. And beneath the Cooper's ligament is the pectineus muscle, and along with the Cooper's ligament, pectineal ligament is the iliac fascia. So this is the femoral ring, and it continues below, as we can see in this diagram, that it continues below and opens in the saphenous opening. So this is the femoral canal. It starts from the femoral ring near the pubis, at the level of pubis, and it continues downwards and opens into the saphenous opening. And as seen, posteriorly is the Cooper's ligament, anteriorly is the inguinal ligament and the fascia transversalis, and the fascia transversalis fuses with the fascia lata and continues as the anterior border. So as you can see in the diagram very clearly, the anatomy is slightly confusing of the femoral canal. So please go through it very carefully. So the femoral canal, which is the space in the upper medial aspect of thigh from the femoral ring to the saphenous opening, also called as fossa ovalis. Its length is around 1.25 to 2 centimeter, and femoral ring, we have seen the boundaries, that is lacunar ligament medially, anteriorly the inguinal ligament and the iliopubic tract along with fascia transversalis. Posteriorly we have Cooper's ligament or pectineus muscle along with fascia iliacus, and laterally we have septum surrounding it from the femoral vein. Then the femoral canal is formed by two fascial layers, that is the anterior layer, downward prolonging of the fascia transversalis below the inguinal ligament, and posterior layer is prolongation of the fascia iliacus behind the femoral vessels. So this was about the basics of the femoral canal. So femoral hernia, when the abdominal content, some intestine or something, passes through the femoral ring, traverses the femoral canal and exits through the saphenous opening, and it takes a retort shape. It goes down and comes upward. So course of femoral hernia, downward up to the saphenous opening and then upwards once it exits the saphenous opening. And it has the tendency to go extend upwards due to the firm unyielding falciform process, attachment of Scarpa's fascia to the fascia lata just below the saphenous opening. So Scarpa's fascia is attached to the fascia lata just below the saphenous opening, so it takes a turn upwards, and there is repeated flexion of the thigh. Now we see the covering of the femoral hernia, that is skin, superficial fascia, cribriform fascia, femoral septum and fibrofatted tissue of the femoral canal, then fascia transversalis and peritoneum. Then some rare forms of the femoral hernia, that is prevascular or Narat's hernia, where the hernia passes behind the inguinal ligament in front of the femoral artery. So the hernia will be in front along with the femoral artery, in front of the femoral artery. And it is associated with congenital hip dislocation. Here is, we can see in the diagram, the Narat's hernia. Then the pectineal or Clockett's hernia, where the hernia passes between the pectineus and its fascia, that is down below, that is Clockett or pectineal hernia. Then we have lacunar or Langier hernia through the defect in the lacunar ligament, that is medially. Now coming to the epidemiology, it is the third most common hernia after inguinal incisional hernia. Women are more prone as their pelvis is large and femoral ring is wide, and also it increases in multiparous women, uncommon in children, mostly seen after 50 years of age group, more common on the right side, 20% bilaterally seen. The clinical features will be swelling below and lateral to the pubic tubercle. So the site is very important, that it is below and lateral to pubic tubercle. Reducibility and cuff impulse may not be very prominent in femoral hernia due to adherence of the content, narrow neck of sac. 40% present with complication, either obstruction or strangulation. Gore sign, that is distension of the superficial epigastric and circumflex celiac vessels. Now the clinical aspects of the surgery, that is surgical details. We have three surgeries, that is McEvedy high operation, Lothesen operation and Lockwood low operation. We'll see one by one them in detail. So first we see the Lothesen operation, where we give inguinal incision, which is similar to inguinal hernia repair. The external oblique is opened, inguinal canal is entered, cord is separated and retracted upwards. Then we open the fascia transversalis, neck of the sac is identified as in the diagram. The sac is dissected, opened and reduced. Then the femoral ring is obliterated by suturing the conjoint tendon to the pectineal ligament of Cooper. That is the anterior aspect conjoint tendon, which is the part of the inguinal ligament, is attached suture to the pectineal ligament of Cooper, and then we can close. Then next is the Lockwood low operation, where we give incision 1 centimeter below and parallel to the medial portion of the inguinal ligament, and the sac is isolated, freed up to the neck and opened at fundus. We have to take care while incising the lacunar ligament medially to free the sac, because sometimes there is obturator artery which is aberrant, which may be present there, can cause bleeding. Then as we see in the diagram, that femoral hernia, posteriorly is the Cooper's ligament, anteriorly the inguinal ligament, and the femoral hernia is reduced. Then we take interrupted sutures and tied from medial to lateral without compressing the femoral vein. Gap is filled and reinforced with plug of mesh, and like how the opening of the femoral ring is closed. Then McEvedy high operation, that is vertical incision over the femoral canal and upper portion of the lateral inch medial, half inch medial to the linea subsemilunaris, as we can see in the diagram. So vertical incision over the femoral canal with upper portion half inch medial to the linea semilunaris, and anterior rectus sheath is incised, rectus is retracted medially, fascia transversalis is opened. Sac can be seen going underneath the inguinal ligament. So below the inguinal ligament, it is dissected, opened, and contents are assessed and reduced. Peritoneal cavity can also be checked. Femoral canal is repaired from inside by approximating the inguinal ligament to the Cooper's ligament without compromising the femoral vein, which has to be taken care, and it is the procedure of choice in case of strangulated femoral hernia. We may also reinforce the defect with mesh. So this was all about femoral hernia. Hope it has been understood, and please like, share and subscribe. Keep studying, keep growing, and never give up because great things take time. See you in next video. Thank you.